Welcome back, everyone. Welcome to another virtual morning report. Really excited. I'm presenting a case actually today to Steph and Zaven. Steph, do you want to say a word?
Hi, everyone. Great to see you. New faces, familiar faces. Excited as always to do some medicine with you guys. And it was fun to see Yusuf and a couple other CPS team members at the Society of Hospital Medicine conference recently. Really fun
Yeah,
getting to see
likewise.
people's faces outside of a Zoom square from time to time.
Yeah, and 3D.
Hi, everybody.
Oh, hey, Hashem. Nice to see you.
Good to see you too.
We're
Thank you, David, for
small.
describing.
Oh, David, yeah, it's scribing. Thank you for doing that. I was going to say we're a small but mighty group, so we can have this be kind of organic. If people want to throw stuff in the chat, or you feel like unmuting at any point, we don't have to be too formal about it as we get to learn from Yusuf.
Okay, so the case today doesn't have like one clinched diagnosis. There's no like one test that confirms the diagnosis. So I don't want anybody to be disappointed that there is no like clear like with a bow on it. But let me start presenting. So this is the case of we have 7 aliquots for today. This is a 90-year-old male. He has a history of hypertension, and he was presented to the hospital after being found down. So per the family, the patient fell and was fell while in the shower, and he had a hard time getting up from that position. He was basically on the ground for a little bit and then woke up and was able to get to a phone, and that's when they brought him to the hospital, and that's the initial like history.
Thanks, Yusuf. And at first I heard 19, but it looks like it's 90-year-old patient. I actually like the diagnostic challenge of the chief concern found down. Found down, right, means someone was down on the ground and someone found them. And there's just so many possibilities of why that happens. And I think it's a lot of fun because we get to decide early whether the schema is going to put us into a systemic illness that made someone, weak and feel bad, like a sepsis, or did they actually syncopize, or was there trauma? Honestly, it can be anything when you hear that. I think the other thing about found down that sometimes is interesting is depending how long they've been down, the sequela of sort of lying there on the ground, potentially with injuries, without any access to food and drink for a period of time, often causes its own secondary problems and diagnoses. So depending at what point in the case you meet the patient, it's just, I think, important to tease out what caused them to actually not feel well and end up on the ground, and what resulting ramifications happened out of that. But I think it could be kind of so many possibilities in this older gentleman that kind of getting as much collateral history as we can, importantly, medication list is a key step early on. You like found down too, don't you?
I don't like to be found down.
Fair enough.
Yeah, I don't know. Like is a strong word, maybe. I think it gives me a lot of anxiety because how almost infinite the degree of possibilities is from something as kind of benign and mundane as the baseline functional status is so limited. There's so much, muscular deconditioning and arthritis and all this stuff that, the patient maybe could still get around, but if they do fall, it really is very hard for them to get up by themselves, right? Because getting up from the ground is very different from getting up from a chair or a bed or just walking. So it could be just that, right? Or it could be everything from, a pneumonia of 200 or acute intracerebral arterial occlusion, like, and everything in between, and head to toe, and fingertip to fingertip. So I think that's why it's very intellectually fascinating, but I think also just very nerve-wracking because things are so broad, and you're starting off without much of a much of a lead, without a starting point, without
Yeah.
anything to like hook onto. So that's why if the patient is able to tell the story of, how they were doing before this happened, the last couple of days, kind of give a play-by-play. And certainly if they have any symptoms, that can be a good place to start. And then actually doing a much more thorough physical exam than you might on a patient who actually comes in with a chief complaint that allows you to focus,
Yeah.
right? Because not only, again, could there be a clue to why the patient fell, but there could also be consequences of the fall that you find that could be important not to miss.
Give us some more, Yusuf.
Yeah, and I'm gonna present this like real life to simulate real life. So he came in, and initially they were worried about a possible like left facial droop. So they were worried for a stroke. So initially, like, what stroke was called. They did like a CT and MRI, and they did find like a small infarct in the left paramedian occipital lobe. And then, as part of the stroke workup, they got a CT of the neck as well, which did show some stenosis of the ACA, or like ICAD, like intracerebral atherosclerotic disease. And he was noted to have cervical stenosis as well. So neurology was consulted in the ER. He was initiated on aspirin, Plavix, and statin, and they admitted him to medicine for further like stroke workup. And notably, during that time, he apparently like stood up and had jerking like movements. So also they gave him initiated on anti-epileptic therapy and admitted to medicine. And this is when I like came in the next morning, and this was the history that I had in the chart.
Thank you. Han, I just saw Hans say, thank you, Yusuf. I just saw Hans say, we can almost expect that in a 90-year-old patient. And I don't know, Hans, if you're referring to the imaging findings, like the stenoses. Yeah, so I was thinking the same thing. Like, I think early on, when you see some atherosclerotic, stenosis, whatever, it could just be an incidental finding, right? Because it's just so common to have that. And the question is that really related to what's going on now? Now, if the MRI showed an acute infarct, that would be a different story. Could you clarify, Yusuf, were they able to characterize the acuity?
Yeah, and they call it small acute infarct in the left paramedian occipital lobe.
Interesting. But no sort of diffusion restriction or other signs of kind of recent ischemia elsewhere.
Right.
Interesting. Okay, and then developed jerky movements. Definitely would love to hear more about that. When you just hear jerky movements, whether another clinician or a family member or patient describe them, that can span a spectrum from from myoclonus, right? That could be related to medications, metabolic abnormalities, sort of benign causes, degenerative disease, or it could be epileptiform activity, right? Or it could be some other abnormal movement, a tremor, or sort of, how there's the fast phase of nystagmus? Similarly, when you have weakness or tremor or other things where sometimes you sort of like overcorrect or catch yourself, even truncal asterixis can sort of look like jerking, for example. Yeah, I think the devil's in the details there in terms of how strongly we suspect seizure activity. And then the actual sort of description, even if it does seem like a seizure, it might be helpful to kind of know whether what was moving, whether there was preserved consciousness, things like that. So that's what I'm thinking so far. But certainly the acuity on the MRI, as well as this possibility of like a new kind of epileptiform or other neurologic symptom, does kind of shift the focus to the brain itself, potentially, and create sort of a more narrow problem representation than just found down. Those are my thoughts.
The only thing I'll add is kind of being in the position you were, Yusuf, of picking up this patient, right? 20 hours into their admission. It's such a challenging skill because so much has been done. A lot of findings have often been identified and acted on, right? And this patient is very much kind of getting a neurologic lens. But I have learned sometimes the hard way, and having kind of delayed finding things, just iterative history and exam on what the initial events were, particularly with rollover admissions that you're inheriting, ends up being really helpful just to make sure the momentum of all the initial workup and results takes us in the right direction. Back to you, Yusuf.
Yeah, I love that. So initially when I saw him, he had very minimal like deficits, maybe a minimal like left pronator drift, but that was it on exam. He was like his strength was intact. The daughter reported that he stood up to walk and started having like movements in his like left upper extremity that they hadn't noted before. And the initial like stroke workup was initiated, so he got a an echo which showed a normal EF, but a dilated LA, dilated right atrium as well. He was placed on telemetry, which did not show any AFib. He got like A1C and RPR, TSH, and a lipid panel that were initially like within normal limits, nothing like too significant. He was evaluated by physical therapy and occupational therapy and did okay. Neurology said that maybe this was a seizure related to a new stroke. They continued the antiepileptic for a little bit. They reviewed the atherosclerosis as well, and they initiated him on DAPT for 3 months. However, he was discharged at this point, and then re-presented 3 weeks later for syncope. So he was at home. He had gotten out of the bed, and 10 minutes later, he was like slumped over, more confused. His daughter checked his blood pressure, and then his systolics was in the 70s. And she reported this happened maybe twice before he came in. And at this point, he came into the ER as well. He reported some dysuria. They gave him 2 liters of fluid and admitted him to my service for a UTI. He other history is like he lives alone, doesn't smoke or drink. And I'm gonna pause there.
Interesting. So the sort of first part of the story ended with, a cerebrovascular events being the potential etiology for him being down, initiated on dual antiplatelets to prevent, right, further events in the near future, but then sounds like developed symptomatic hypotension at home. What the hypotension was from is up to us to figure out, whether the urinary symptoms are a sign of developing urinary tract infection or anything else. One question I have, Yusuf, is were other medications, including his antihypertensives, adjusted at the prior stay? Just to think of cause and effect of the last stay with now the representation.
They were not adjusted, but he was on antihypertensives, which I will give you the list of meds in the next adequate, but he was on blood pressure meds.
Yeah. So on his meds, hopefully even more adherent to them now that he's recently had a stroke than he was. By the way, is that why he's hypotensive, right? Sometimes it's hard for patients to take all their meds, but if they have some health event or other moment of realization that they should be taking them, they take all of them at once and they didn't need all of them. Just something to think about in the background. But I think given how low his blood pressure is, some of the other symptoms that he's having, thinking about other drivers besides just resumption of his medications for symptomatic low blood pressure is going to be really valuable.
I am reading the chat, and
Yeah.
I actually, I'm gonna risk losing all my, street cred here with Mark and John, who are, really amazing, thoughtful, experienced internists here. And I'm going to try to convince you guys that UTIs commonly cause syncope. That is my experience, okay? I'm risking my whole professional reputations on this, but I hope I can make a case here, all right? So, first question. Pasha, can an infection in the urinary tract, prostatitis, pyelonephritis, can it sort of evolve into systemic effects, cause sepsis and hypotension? Can it, Hashim?
And I know that UTIs can commonly lead to like altered mental status. So I mean, I think it makes sense to me that they can be systemic.
Sure. Have you seen a patient, have you heard the term urosepsis, or have you seen a patient who had a UTI that became bacteremic?
I have never known.
It happens all the time. It's really common. Okay. So, UTIs can cause sepsis, right? And they can cause hypotension, even when you're lying down. And the mechanisms of infection anywhere, systemic infection anywhere, causing hypotension is vasodilation, capillary leak and third spacing from the inflammation, intravascular volume depletion, essentially, or again, the vasodilation that leads to very low preload, right? But here's the thing. Before you're hypotensive supine, so imagine a patient who is in this process, okay, of they don't have septic shock yet, right? But they do have some systemic inflammation, vasodilation, third spacing. Maybe they're also not feeling great and they're like haven't eaten as much, whatever, right? They're not yet hypotensive while lying down, but they've got enough of a loss of vascular tone and preload and all that stuff that when they stand up, their blood pressure falls, they're orthostatic to where they get woozy and slump over or fall down or whatever. So I think actually vasodilation of whatever cause, but more commonly infectious cause, and UTIs aren't special, it could be pneumonia or anything else. I don't know, in my experience, are not an uncommon cause of orthostatic hypotension. On their way, again, everything is on a spectrum, and before you get supine hypotension, you can get orthostatic hypotension, which can cause syncope. So that's my case, and it was good knowing y'all. And this will be my last VMR, but I do think it's possible. I actually don't know how super common it is, and I do want to just validate. Obviously, I think what Mark and John were saying is they were sort of alluding to the fact that we often misdiagnose, overdiagnose UTIs on sort of an insufficient basis without adequate evidence, through the same mechanism that sort of that Hans alluded to, where many older patients have incidental colonization and bacteriuria, right? There's a lot of causes of incidental and sterile, non-infectious pyuria. So do we overdiagnose UTIs? Yes. But is it also possible that this patient describing dysuria actually also had systemic effects from that infection and sort of was hypotensive, slumped over, whether orthostatically or not, as a result of it? I think it's possible. What do y'all think? John, Mark, are you ever going to listen to anything I say again?
Yeah, that's legit. I'm always just I come in with that frame of skepticism because I'm used to getting a lot of phone calls with everyone kind of gets the urinalysis checked, and then it's kind of sometimes we stop thinking a little bit too early once they see some nitrates or WBCs in the urine. So I just want to make sure we keep it broad. Don't anchor on it.
Totally with you.
Back to you, Yusuf.
And before I give you the next aliquot, I just wanted to ask you, how do you teach others to take orthostatic vitals? Because that's what you will get in the next aliquot. So how do you teach it, and what's the technique?
My go-to is if you Google CDC orthostatic vitals, the very first hit, you can fact check me now, is a PDF that outlines a worksheet. And it's nice because it tells you how to do it, but you can also print that out if you're teaching someone to do it, or you want to talk to the nurse who's doing it. What that worksheet from the CDC suggests, at least, is the patient should be resting for 5 minutes supine, take their heart rate and blood pressure. And importantly, at every stage of this, you want to ask them how they're feeling. Because I think Austin already made a point that patients can be orthostatic, but it may not at all be the explanation for their symptoms or their syndrome. So a key thing that's often missing is what are their symptoms as you're taking it. But this worksheet from CDC recommends 5 minutes supine, heart rate, blood pressure, no sitting. I feel like often it's done with a sitting stage, but go right to standing up, and at 1 minute and then 3 minutes of standing, record the heart rate, record the blood pressure, and ask about symptoms. Are they having the exact same dizziness, lightheadedness, whatever that they have that make you worried in the first place about it? Is that what you do, Yusuf?
Yes, yes. Then there was a review paper that in older patients, in younger patients, 1 minute is usually sufficient, and in older patients, you might want to wait till 3 minutes, and that is my practice. So in this case, you start doing like a review of the meds. So they're on aspirin, clopidogrel, atorvastatin, mirtazapine 7.5, amlodipine, benzapril combo pill, and donepezil. On initial vitals, he was normotensive. His systolic blood pressure was 110/65. His heart rate was 103. His exam was notable for only like a mild left pronator drift, but otherwise his strength was intact throughout. And his other exams were essentially normal. His orthostatic vitals, so while lying down, his heart rate was 88 with a systolic blood pressure of 123 over and diastolic of 63. And then when he stood up, his blood pressure went to 81/61, and the heart rate was 89. And I'll put those in the chat shortly. So the heart rate did not change significantly. The systolic dropped by 40 points. And he did feel very dizzy, and we had to lie him down again and raise his legs, and then he felt better. And I'm going to pause there.
Yeah. Something like a quarter of people above age 65, 70 have just orthostatic vital signs without kind of clinical orthostatic hypotension, just to state that clearly and again. But this seems different, right? Because the patient is symptomatic. And again, we're seeing the patient in the context of having come in with syncope. And again, they're like dizzy when they stand up. There's a significant drop. Yusuf emphasized with his voice a little bit and his cadence pacing, the fact that the heart rate did not go up. And in fact, for what it's worth, it went down while the blood pressure went down. And that's actually a really useful thing to look at, because if you are orthostatic from purely hypovolemia, low preload dependence, when you stand up, your preload drop, your stroke volume drops, and your aortic arch and carotid baroreceptors feel that. There's a sympathetic outflow, and the catecholamines make your heart rate go up, right? So if there's any runners in the group, if you go on a long run on a warm day and you're sweaty, a little dehydrated, whatever, you lie down, catch your breath, and then quickly stand up. You might feel a little bit woozy, right? I think a lot of us have felt that. And if you feel your pulse, when you stood up, your heart rate kind of shot up to try to compensate and not let you faint. So if the cause is hypovolemia, the heart rate goes up. But when the heart rate doesn't go up, you actually wonder whether there's an interplay or mostly the effect of autonomic dysfunction as the cause of the orthostasis, or again, if meds are in play. But this person isn't on a beta blocker or other sort of chronotropic agent. So that's not an easy explanation. Now, he is 90 years old, right? So he could have sinus node dysfunction, or again, just sort of autonomic dysfunction just by virtue of an accumulation of toxic metabolic and other injurious insults on his autonomics over the 9 decades. But again, that's what the heart rate tells me. But because of his age, I wouldn't just say that this is, this doesn't rule out a low preload sort of systemic infection or other cause like that. Benzapril, who's donepezil. Let's see, that's David, good point. Okay, that's a cholinesterase inhibitor, more acetylcholine, slower heart. Okay, yeah. Mirtazapine. A lot of psych meds have sort of like effects on various receptors. I don't associate mirtazapine. I don't think it's typically associated with, it's not very anticholinergic, shouldn't be associated with orthostasis, but I wouldn't be surprised if it's a rare side effect. And then the amlodipine, benzapril, definitely, I would blame that, right? Like that's a vasodilator. Again, that doesn't explain why the the heart rate didn't go up, but it definitely gets in the way of, vasoconstriction, vascular tone, and can cause orthostasis by all means.
I love this discussion. So mirtazapine was held, donepezil was held, the antihypertensives were held. He was fluid resuscitated on multiple days. He received many liters of fluids. Blood cultures remained negative, and he did complete a course for a UTI. Other like workup was initiated. He got an SPEP and a UPEP that were within normal limits. He got a kappa lambda. The ratio was like 3.5. His B12 was within normal limits. And then at this point, he was still having orthostatic symptoms. So and then I'm gonna give you what neuro, like they reevaluated him at this point, and they were wondering if could he have been on initial admission? Was he initially hypotensive? Could that have caused a small stroke from his cerebrovascular disease as opposed to a stroke causing him to pass out? They weren't sure about the causality. They were like, a small occipital stroke does not explain someone passing out. So they were worried about that. And then we also discussed the like cervical stenosis. They also said without weakness, without bladder symptoms, without any like neurologic symptoms, they don't expect like this autonomia just from like the cervical stenosis. So they were like also questioning that as well. And I'm gonna pause there and ask you like, what would you do next, or what are you thinking?
I think first of all, like just great approach at this from multimodalities, right? The chat has been all over, first of all, recognizing orthostatic hypotension not as its own diagnosis, right? But a syndrome of low preload, medication effect, autonomic dysfunction, whether it's systemic disease or neurodegenerative. And kudos to ortho for neuro for coming in and just sort of reframing this whole prior view of the stroke and recognizing the location and the size didn't explain why he fell down the first time. And he's still orthostatic despite the fluids, despite holding the medications. So I think we've had a test of treatment almost at saying, is low preload a problem here? Doesn't seem like it. Is medication excess the main driver here? Well, not the only main driver if it's still ongoing. So I think in real life, it would make me want to think about some of those other categories. In the chat, it was mentioned, systemic things that cause autonomic hypotension. I presume that's why the search for monoclonal gammopathy went on, to look for things like AL amyloidosis that could do it, but systemic amyloid, he had an A1C already, doesn't show advanced, right? Severe diabetes that could do it. But here's where like an iterative neuro exam, particularly with the neurologist, as well as more history about other symptoms of autonomic dysfunction, right? Are there issues with bowel and bladder, et cetera? A more detailed neuro exam, looking for findings that go with essentially neurodegenerative conditions that can precipitate with this, I think is an important piece. Again, recognizing there's been some really thoughtful comments in the chat about just who's the host and what do you just expect for someone who's 90? And there's just been thoughts about, we expect a little cerebral vascular disease. We expect a little dilation of the atria, and expecting some, trying to think of like a pithy way to say it, but expecting like some kind of problems with maintaining sort of vascular tone, depending on what his lifelong risk factors is there. But again, this is a new thing for this guy. It just started in the last couple of weeks. He's feeling really badly from it. So I think my sort of next approach here would be to think about the systemic things that haven't been checked. A lot have, but making sure there's no signal for adrenal insufficiency, for example, and then really kind of thinking about neurodegenerative processes and getting more info on history and exam. By the way, and there's more you could do non-pharmacologically to help him in the meantime, right? Abdominal binders, pressure stockings, everything you can to keep that venous kind of input closer up to the brain and not pooling in the legs. So many behavioral things that can be done in terms of his changing position, diet, liberalizing salt. There's a lot that can be done, but again, still kind of need to figure out the diagnosis here.
Nice. I was thinking about the last thing you said. I think that's so important, right? Because orthostatic hypotension may be what it is. We may find a cause for it or not. We may be able to reverse it or not. but it's one thing to have your body be unable to tolerate postural changes as well, and it's another to fall and break your head because of it. So I think it's really important, and we don't do this enough, of talking to patients about how they can keep themselves safe given the reality that they have, autonomic neuropathy and orthostatic hypotension. Because that can be true, and there's things you can do to fall less as opposed to more, right? So just some of those behavioral things that PT is often very good about kind of counseling in terms of sitting at the bed, waiting, doing isometric tensing exercises, kind of contracting and relaxing your quads and legs 10 times before you actually stand up, kind of being attuned to the earliest kind of experience of lightheadedness or whatever, and being quick to sit again or find a wall, or kind of have a controlled fall as opposed to an uncontrolled fall, right? Anyway, those things can make a big difference. No, I might have missed this, but I'm really wondering, when were these antihypertensives and donepezil and mirtazapine prescribed?
Yeah, good question. So that was my question as well. And they said that they had a PCP, and the PCP said that maybe there's like possible early dementia. So like donepezil was started outpatient at some point, like before all of this presentation. And the same PCP prescribed the antihypertensive. This is all like significantly before these presentations. And then the mirtazapine was initiated at like the prior admission. There was like some concern for like malnutrition, and they were like, oh, is he not eating enough? And they started like a low dose mirtazapine, like 7.5 Q nightly.
Thank you. Yeah, I mean, I think if these were just like all started a month before he was found down, and then he came in with this, and that would be easy. But now it's like, I mean, it's almost as easy of a thing to potentially blame and undo, just because the fact is now he's, hypotensive, orthostatic, while on antihypertensives, right? So I think I'm not saying not to think about what changed, since he was tolerating these meds and now he's not. But I think it's obviously very clear that he shouldn't be on them anymore. But
Yeah, and similar to what you all were suggesting, we started like symptomatic treatment, compression socks, abdominal binder, and this was very, very difficult. So he had like, for example, 2 days after, he also with PT had a syncopal episode, also orthostatic, had like a change in augmentation, a code stroke was called, like repeat stroke workup was negative, and he was persistently hypotensive as well intermittently. His hospital course was also like complicated by an AKI that resolved afterwards, and GI bleed as well that also like underwent an EGD that also resolved. But despite all of this, he was still like intermittently orthostatic. He did get scans intermittently here. He got a CTPE that was negative. He got a CT abdomen pelvis, which did not show any like masses or malignancy. And I think next aliquot will reveal the diagnosis. And I was wondering if you wanted to do breakout rooms before discussing, since we have time.
sure.
Okay.
Yeah,
Yeah.
let's do it. Yusuf, just one more question. Just like sort of basic labs, inflammatory markers, nothing?
To add to that, so an AM cortisol was normal, and his labs were nothing like stood out. The CRP ESR was within normal limits. The AKI like resolved after like fluids, so it wasn't like persistently there.
Okay.
He did have constipation intermittently, no urinary symptoms.
Yeah. Sure. Let's take a few minutes to chat in small groups, shall we?
Yeah, it was that I was gonna say Zaven was being punished for the UTI causes everything comment.
Contemplation corner. That's a good euphemism. In one of our kids' classes, they call it the thinking chair. And you go sit
No,
in the
it's called
thinking.
the peace chair.
Yeah,
Peace
the
chair.
peace chair. Yeah. So what did people talk about? Let's hear from y'all.
Your new dog. Your new dog causes orthostatic hypotension, Anne-Marie? Danger.
I think one thing I wasn't paying as much attention to is, but I do want to comment on real quick is the I think someone in the so the echo, right? Um, the large atria are not only a sign for chronically elevated intracardiac pressures. This patient doesn't seem to have a kind of a heart failure clinical phenotype, but again, it's not totally normal. And age isn't really an excuse, right? Like age is a risk factor for disease. So not all 90-year-olds have autonomic neuropathy, right? But 90-year-olds who have had a lifetime of enjoying a few margaritas and having some diabetes and having had chemotherapy 30 years ago for their breast cancer or whatever, like that's what accumulates, and then it is a disease, right? So anyway, large atria, but they're also set up for atrial fibrillation and flutter and other arrhythmias and stasis that can lead to cardioembolism. And even though this patient has ICAD, and even though the stroke that we have seen was not explanatory, you can have emboli or atherosclerotic sort of thrombotic events that self-recanalize, right? So PIAs that can cause a variety of neurologic symptoms and have sort of a central, source. Anyway, so that's part of why I'm kind of thinking about the heart. And the other was something that was mentioned is just thinking about amyloidosis as sort of a systemic disease that can affect heart, nerves, of course, kidneys, blood vessels, GI tract, constipation, like all that. So I think one thing that I guess has been done, and doesn't explain to orthostatic hypotension necessarily, but just to look for do like more prolonged rhythm monitoring for AFib. I think the bubble study, I saw someone say, did I just totally imagine that? Did I just hallucinate somebody mentioning a bubble study? Maybe I did. Anyway, Steph, anything else?
I think one thing we're talking about is the reality is you might not leave the hospital with a diagnosis, but all of these minimizing polypharmacy, behavioral coaching, and other supportive measures. I mean, we do that a lot. We discharge a lot of people in the hospital with that sort of plan without a clear etiology. I think without other signals of neurodegenerative disease here, it doesn't seem like there's other signals of organs kind of compromised that would be present with another type of amyloidosis. I feel a bit stuck on whether we'll find kind of one thing for him versus tincture of time and minimization of high-risk medications. Excited to hear how you handled it, Yusuf, and what you found out.
Yeah, so I'm gonna go through this patient helped me build a schema for orthostatic hypotension. So like you all mentioned, initial layer is hypovolemia, any cause of shock, like you mentioned, and then review of meds. And then second layer is adrenal insufficiency, which was ruled out. Third layer is ruling out other neuropathies, like you mentioned, looking for generalized neuropathy, which in this case also ruled out. And then the fourth tier is reversible etiologies that present with this autonomia. So this includes vasculitis, like you mentioned. Sjogren's is a good one. In this case, the workup was negative. Other things include Lambert-Eaton or paraneoplastic autonomic neuropathy. So in this case, his PAN scan was negative for any cancer. He did end up with a paraneoplastic panel that was also negative. There's also ganglionopathies that present with pure autonomic failure. So this includes acetylcholine receptor antibodies that present as a ganglionopathy. In this case, this was checked and this was also negative. And after you rule out all these reversal etiologies, what you are left with is neurodegenerative disease, which may or may not be related to dementia. So for example, in multi-system atrophy, Parkinson's, Lewy body dementia, or pure autonomic failure, the dysautonomia can present years before the dementia. And in this case, somebody did prescribe donepezil, and there was a reason why they prescribed the donepezil. Could this early dementia have been like a harbinger of another synucleinopathy happening in the CNS? And in this case, that's what we thought, and we considered also ATTR amyloid. There was this could this like dilation on the TTE been a sign of ATTR amyloidosis? The current treatments for ATTR amyloid affect the heart. I'm not sure they affect the nervous system. So I don't think this was pursued in patient, as it doesn't necessarily affect how we will manage this patient. It might lead to diagnostic closure, but the PYP scan was not performed. We did the SPEP, but we did not perform like a PYP scan. And then there's the presumed diagnosis in this case was primary like dysautonomia question mark related to dementia. And this is where the management gets really tricky because this patient has cerebral vascular disease, and if they become hypotensive, they develop a stroke. But if they become too hypertensive, do they also develop a stroke? And the question is, do you start antihypertensives or do you give midodrine? Like, which one do you give? And there is a study of patients who have orthostatic hypotension, but are hypertensive. They are higher risk for stroke. So you should continue your antihypertensives in those patients. But that's the condition, is that if they are asymptomatic. In this case, he is symptomatic, so you cannot give antihypertensives. So it was really difficult. So we tried to treat supportively with like salt tabs, fluids, compression stocking, abdominal binder. And he was referred to a autonomic specialist to follow with outpatient after going to rehab. But that's the case.
Love that, Yusuf. I love the schema and the inclusion of sort of thinking of the, as you said, the paraneoplastic conditions and ganglionopathies in the right host. It's just really comprehensive and well done. And I think he was lucky to get your thorough eval in this case. Other final thoughts or reflections before we turn it over to Harry for teaching points?
No, just emphasizing like the time spent with the patient to help them, empower them with the knowledge, habits, motivation to kind of try to mitigate the effects of the disease and keep themselves safe from falling and stuff. And then I just want to mention, like, we actually have like an amazing vascular medicine group as part of our general medicine section here at the VA. And we see a lot of veterans who have bad supine hypertension and orthostatic hypotension. Like, it sounds like this guy wasn't that hypertensive, but we see folks who, like, when they're lying down, their blood pressures are like 200 over 90, you know? And then they stand up and it's like 120 over 70 and they're passing out, if not lower, you know? And in a lot of those patients, our group here recommends doing nighttime captopril. Bingo, Austin. Yeah, because it's a short-acting ACE, right? That basically allows them not to be in the 200s while they're sleeping all night and to have a hemorrhage, right? But also wears off by the daytime when they're trying to walk around.
Harry, we'll turn it over to you.
Awesome case. Yeah, I'll have to add the captive part. I haven't gotten to that part, but that's a good thing to know. So we talked about a very broad differential for being found down. Pretty much everything under the sun is possible. So weakness, syncope, trauma, med side effect, infectious, toxic metabolic, etc., as well as stroke. But basically, it comes down to getting history and collateral, and as always, a good exam. Briefly talked about not all jerky movements equal seizure. So consider tremors, consider clonus, asterixis, and then getting to the meat of it, we talked about syncope, orthostatic hypotension, autonomic dysfunction. So really what we had a good discussion about syncope, really comes down to low cerebral perfusion or hypotension. Very broad differential, as always. Something we'll see a lot is either it's a cardiac output issue related to volume or obstructive physiology, low outputs. Arrhythmia is decreased sympathetic tone, like including vasodilation from sepsis, from UTIs, we talked about as well. Increasing parasympathetic tone like vasovagal, and then shunting, as well as carotid stenosis. Orthostatic hypotension, super common. I think Zaven had said, 10 to 30% of people can have positive orthostatics, but not everyone's symptomatic. So it's really the symptomatic folks you want to look out for. And there should be a chronotropic response, meaning increase in heart rates. If there isn't one, think about autonomic dysfunction, like in our patient here. Med effects, including cholinesterase inhibitors like donepezil, and sinus node disease. And then for autonomic dysfunction, very broad differential that Yusuf walked us through, including diabetes, amyloid, neurodegenerative diseases like Parkinson's, Lewy body, as well as age, vasculitis, adrenal insufficiency, and some mostly conservative management with compression stockings, bindings, behavioral modifications, and then quickly talk about left atrial enlargement, basically sequelae of chronic cardiac remodeling from either age, hypertension, diabetes, in some cases, amyloid, as well as AFib is also a risk factor for AFib as well. And that's all I got. Thanks, everyone.
That was awesome, Harry. Yusuf, just thanks for the great presentation and sort of teaching along the way. And I just want to say, like, for me personally, I don't know, these cases and diagnoses that are, you know, seen daily and don't seem that fancy, are actually, yeah, just fascinating, complicated, like always, you know, more to learn. So thank you for bringing this case, and thanks everybody for joining today.
Loved it. Thank you, Yusuf.
Thank you all so much.
Have a great day. Bye.